Pain Management and Addiction by Dr. Kyle O. Pain management. What is pain? Pain is defined as any unpleasant sensory or emotional experience. What a pain specialist treats is mainly the physical or the sensory component of the pain. Without delving into the pathophysiology of the physical pain, we will simply define the pain as any unpleasant sensory experience arising from a physical injury. Philosophy of pain management. The job of a physician is to help eradicate pain by curing the cause of the pain when possible, and to help patients manage the pain the best they can when it is not. Pain management is not necessarily the elimination of the pain. The main goal of pain management is to improve the quality of life and restore function to the best level possible. Methods of pain control or elimination. The best arsenal in treating pain is the body's own natural healing process. Most injuries heal on their own. The body has an amazing restorative capability. Sometimes a physician must educate the patient about the natural course of an injury and the time required for this to take place. While healing is taking place, a physician can help the patient control the pain by various means. This is usually done in a stepwise fashion, starting with the least aggressive or invasive means and adding stronger measures as needed. Pain control does not start with the use of strong opiate pain medications, but often starts with over-the-counter analgesics such as Tylenol, acetaminophen, and ibuprofen. The first tier in the treatment of pain is always with behavior modifications. A patient must be made to understand that he must heed the pain as a warning sign that his body is trying to tell him what to avoid. Rest is essential for any healing to take place. This does not mean bed rest, but avoiding those activities that cause worsening of the pain. At the same time, modalities such as ice, heat, elevation, or splinting are crucial in helping decrease the pain. In the second tier of pain management, the use of the over-the-counter medications are used as mild analgesics. Tylenol, as well as all non-steroidal anti-inflammatory drugs, have analgesic properties. They are inexpensive and well tolerated for the most part. Oftentimes, mild pain can be treated alone with these medications. Although for the most part these medications are safe, if used as directed, there are few things to know about them to prevent potentially serious side effects. Tylenol, acetaminophen, can be hepatotoxic, meaning toxic to your liver, if ingested in a large quantity. The upper limit of Tylenol that can be safely taken in a 24-hour period for a healthy adult is 4 grams. This is 8 extra-strength Tylenols. Fatal dose of Tylenol for a healthy adult can be as low as 6 grams. This means that there is very little room for error. You must keep in mind that many of the over-the-counter cold medications have Tylenol in them, so one must know what other medications one is taking to prevent Tylenol overdose. For those patients with liver problem or for those who drink large quantities of alcohol, even the safe amount of Tylenol may be detrimental to their liver. All non-steroidal anti-inflammatory drugs such as ibuprofen, Aleve, etc., have potential nephrotoxic, meaning toxic to your kidney, side effects, especially at high doses. Those patients with kidney problems should avoid non-steroidal anti-inflammatory drugs until they have consulted their physician. More commonly, all non-steroidal anti-inflammatory drugs, except for Celebrex, have potential GI side effects. Most of the time, the GI side effects are minor and include upset stomach, nausea, heartburn, and abdominal cramping. However, in a small percentage of patients, these non-steroidal anti-inflammatory drugs can cause an ulcer, even a potentially life-threatening perforated ulcer. Here, other interventions such as physical therapy, modalities such as electric stimulation, myofascial release, ultrasound, as well as chiropractic manipulations, massage therapy, acupuncture, etc., may have a role. The third tier of pain management involves the use of the opioid pain medications. All opiate pain medications belong in the same class as heroin. Heroin is derived from morphine. Once in the brain, heroin is converted back into morphine. All opiates have addiction potentials, for some. Generally, the stronger the opiate, the more likely one can become addicted. However, we have known that most patients do not become addicted, but that a percentage of patients can and will become addicted. There are patients who are genetically susceptible to getting addicted, whereas most are not. The use of the opioid pain medications have revolutionized the treatment of both acute and chronic pain. It has enabled physicians to help our patients achieve a better quality of life and improve function when used appropriately. As a physician, I understand that some of my patients will get addicted to these medications. Although started with good intentions, some patients may end up paying a high price if not handled properly. Thus, it is a great responsibility to be diligent about how these medications are used, to look for possible signs of addiction, to help patients avoid getting themselves into trouble, as well as offer them a way out if they happen to become addicted. A great fallacy that most physicians were taught was that when opiates are used to treat pain, patients do not get addicted. I tell you that this myth has caused more people more harm than any other statement that I can think of when it comes to the use of opioid pain medications. There is a grain of truth in this statement. It should instead read that when treated appropriately, the opioid pain medications are less likely to get patients addicted. Key to understanding the above statement is that when you do not overtreat the pain, even those who are genetically predisposed to getting addicted are less likely to get addicted. In other words, when pain medications are taken up to the level of the pain, there doesn't seem to be a high risk of addiction. When these medications are used to completely mask the pain or go beyond the level of the pain, in those patients who are genetically predisposed, any extra medication in the brain will cause the euphoria and stimulate the brain, which can lead to addiction. Along with opioid pain medications, there are other pharmacologic treatments such as use of antidepressants and anti-seizure medications that can have a role in the treatment of pain. The right and the wrong way to use the opioid pain medications. Patients must be made to understand that the pain is there for a reason. Pain is a message that the body sends to the brain that there is an injury, and it is designed to prevent further injury from happening by preventing the patient from doing things that can further harm himself. The most important reason for why a diabetic patient develops an infection or an injury that goes unnoticed until it has wreaked havoc on the body is because diabetes often leads to neuropathy, which is a nerve damage that can lead to inability to feel pain. Yes, Most of the time, the pain can be brought under control with the use of the opioid pain medications. These medications can be of great help in improving the quality of life by helping manage the pain. However, the wrong way of using these medications is to use them to block the pain, so the patient can continue doing these activities that cause harm. In other words, if you couldn't do something before you took the opioid pain medications, you shouldn't be doing it after you take the pain medication. Pain medication should be taken so that you can rest and recuperate, rather than continue the activities that are detrimental to you. Opioid pain medications only mask the pain. They do not eliminate the cause of the pain. There are other medications, such as anti-inflammatory medications, that actually decrease or eliminate the pain by getting to the source of the pain. When taking opioid pain medications, one must understand that the cause of the pain is still there. If the pain subsides with the use of anti-inflammatory medications, you are less likely to make the injury worse than when you are taking opioid pain medications. Side effects of opioid pain medications. All opioid pain medications have side effects. The most common of these side effects is constipation. As one increases the dosage or the potency of the medications, the greater is the side effect. Most other side effects, such as grogginess and nausea, vomiting, as well as respiratory suppression, subside with prolonged use. However, constipation does not. Early preventative measures, such as using stool softeners and increased fiber intake and good oral hydrations, can eliminate or manage this side effect. Dependence and tolerance. Anyone taking opioid pain medications for an extended period of time will become physically dependent on them and will develop tolerance to them. Dependence and tolerance are not addiction. Dependence describes the physical state that happens once exposed to these opioids on a long-term basis. This is manifested by physical withdrawals that happen when the opioids are taken away. Anyone who has been taking opioid pain medications on a long-term basis will go through physical withdrawal symptoms. This does not mean that they are addicted. Tolerance in our case is best described as the liver's ability to metabolize these substances better and faster once the liver has become exposed to them for a while. We all know that as a freshman in college, 1 or 2 beers got us drunk. By senior year, we were able to drink a 6-pack before it hit us. Patients taking oral opioid pain medication will notice that after a while it loses some of its effectiveness. However, the liver will not keep metabolizing the medication faster and faster over time. There seems to be a break-even point where tolerance levels off and there isn't any further loss in effectiveness unless the medication dose or strength is increased. This is the reason why, when treating chronic pain, it is important to make the patient understand that increasing the pain medication to achieve no pain eventually leads to the same pain level as when you first started. The reverse is also true. That is, gradual decrease in the opioid pain medication can reverse this faster and faster metabolism. However, every time you decrease the medication, you may experience withdrawal symptoms. Slower decrease will lessen the withdrawal symptoms you will experience. What are the withdrawal symptoms? Withdrawal symptoms will vary in intensity depending on how quickly you are reducing the medication or how high a dose you are coming off of. These symptoms can range from flu-like symptoms, agitation, feeling of doom, elevated blood pressure, quickened heart rate, dilated pupils, diarrhea, runny nose, goosebumps, and abdominal cramps. The physiologic withdrawal usually only lasts about a week. We will discuss the psychological withdrawal symptoms for an addicted person a little later. As stated above, anyone who has been on the opioid pain medication for a long period of time will go through withdrawal when coming off of it. This does not mean that he or she are addicted. Addiction. Addiction is defined as continued behavior in spite of knowing that the continued course will harm oneself. It is characterized by the lack of self-control and feeling of helplessness in the face of such continued behavior. While this describes addiction after it has taken hold, it does not explain why it happens. There are many misconceptions about addiction. We have moralized it by saying that drugs are bad and that we should just say no to drugs. We have equated the behavior with the disease. We confuse abuse with addiction. We have also misled people. For example, when an actor shows a frying egg in a skillet and says, "This is your brain on drugs," besides trying to scare you, the message it sends is that anyone can get hooked on drugs and that everyone's reaction to the drugs is the same, which is false. Only about 10 to 15% of the population is thought to be susceptible to opioid addiction. The rest of us are immune, and every drug addiction has a different genetic basis. The worst thing that we have done wrong when it comes to discussing addiction is the way the high has been portrayed. What does the image of someone who is high look like on TV or in films? He looks stoned, with a glazed look in his eyes, dopey, intoxicated, passing out. Even the term dope is synonymous with illicit drugs because most people think that's what these drugs do, make you dopey. Because kids think that anything that alters their mind gets them high, they think that they are high when they smoke pot. However, most people do not get high on pot. Most just get intoxicated. So when a drug makes someone feel really good, he doesn't realize that this is high. Dopey is not high. Happy is. The high produces the same chemical reaction in your brain that sex produces. It just does it much more quickly and more intensely. It releases a chemical in your brain called dopamine, the feel-good neurotransmitter. That's why one wants to chase that feeling. It's only when such a euphoric feeling is chased and repeated that the craving sets in over time and addiction takes hold. If you have ever been to the movie When a Man Loves a Woman with Meg Ryan and Andy Garcia, there is a scene when Meg Ryan's character, an alcoholic at the end of her addiction, stands up in her first AA meeting and describes her initial reaction to alcohol. This reaction tells us why anyone becomes addicted to anything. She stands up and says, "When I was 15, I had my first beer and I liked it. So I had another and another." Most of us do not remember our first drinking experience. because it was not very memorable. Alcohol for most of us is an acquired taste. However, for those who are susceptible to becoming addicted to alcohol, the first taste of alcohol produces such a highly euphoric and enjoyable feeling that they remember it vividly years later. The reason why some people don't understand why others get addicted is because they do not have the same response to these substances. They say, "Gee, all it does for me makes me groggy and nauseous." They think that others must have the same experience as they do. Why can't Johnny just quit? Of course, if Johnny had the same experience as they did, he wouldn't have gotten hooked. On the other hand, if they felt the same way that Johnny did, they might have gotten hooked as well. Because addiction is based on genetic predisposition, we should treat addiction as a medical illness rather than a character flaw. It is not a weak mind or a lack of moral compass that leads some people to fall victim to addiction, but rather a medical illness that brings about the behavior that we call addiction. Addiction crosses all ages, races, sexes, and socioeconomic lines. For those who are genetically predisposed, it is a lifelong condition. One does not become immune to it with age. Once you become addicted, you are no longer in control of it. It controls you. What an addict wants most is usually to get off the roller coaster ride of highs and lows that addiction brings. However, he feels helpless and is often unable to stop the escalating pattern of addiction despite knowing what is happening. Early on, before a person becomes addicted and loses control, he may not want to stop because he feels good. I often hear early on from a patient who is getting addicted, "Why should I stop when it makes me feel so good?" Later on, after addiction has taken full control and the patient feels powerless, I hear, "I don't want it anymore, but give me more." If something makes you feel that good, what's wrong with continuing it as long as you can get a steady supply of it? The problem is that when the brain is overstimulated too often, the number of dopamine receptors in the brain will increase over time. This is thought to be the reason behind cravings, as well as the reason why normal things that used to give one pleasure no longer do. An addict no longer finds pleasure in the simple things in life like eating or sex. It changes the person. Family members often notice that their loved one is no longer himself. Unlike others who have gotten addicted to street drugs after experimenting with them, a patient who gets addicted to opioid pain medication may not realize that he is getting addicted early on. Because he thinks that a dopey feeling is the high, when the drug makes him feel good, he doesn't realize that he is getting truly high until it's too late. Only when he starts having cravings for the drug does he realize that something is wrong. If one understands addiction and its early warning signs, one can avoid getting addicted by decreasing or stopping the opioid medication. If you take pain medications below the level of your pain, the chance that you will get addicted is much lower. However, for those who get hooked on opiate pain medications, once they are hooked, their pain never goes away. In fact, the more pain medications they take, the worse the pain seems to get. It's only when addiction is brought under control that the pain settles down. This concept is called hyperalgesia. Common early signs that you may be at risk for opioid addiction. Does a low dose of opioid stimulate or energize you rather than sedate you? Do you act like the Energizer Bunny when you take it? Does it cause insomnia? Are you cleaning the house in the middle of the night after you took a pill that you thought would help you sleep? Did these medications make you feel really good, euphoric, or high when you first started taking them? Do you think that this is the best thing that God put on this green earth? Does it make you feel younger? Is it better than sex? Or does it make sex better when you first start taking the medication? Does it promise you the moon? Does it make you feel better than you should even if there was no pain? Unless something makes you feel good, I mean really good, why would anyone get addicted? But if you felt any of these symptoms, you will become addicted with repeated use. Normal versus abnormal responses. Remember that some drugs, such as alcohol, opiates, and pot, are downers, whereas other drugs, such as cocaine, amphetamine, and crystal meth, are uppers. For those who are not susceptible to these drugs, the downers act as sedatives right off the bat. They intoxicate and calm you down. For those who are susceptible to these drugs, they act as stimulants and make them feel euphoric. Even for those who can get high on these drugs, eventually sedation may overtake them as the euphoria fades, but sedation is not the initial response. For drugs that are uppers, those who are not susceptible to these drugs become stimulated and energized by them. But these drugs do not produce any euphoria. In fact, at high doses, most feel wired and jittery and may find the experience very unpleasant. However, for those who are susceptible to these drugs, they can produce extreme euphoria. For them, jitteriness only follows their high. Those who are coming down from their high from an upper do not become intoxicated, but jittery and wired. SUBOXONE and SUBUTEX. So, are you hooked? For those patients who are hooked on opiates, whether prescription medication or street drugs, now we have an effective treatment option. Before SUBOXONE and SUBUTEX came on the market, the only medication available to treat opioid addiction was methadone. Methadone was a dismal failure, because when the patient stops methadone, the craving comes back. With SUBOXONE and SUBUTEX, we can finally treat withdrawal symptoms as well as cravings. The therapeutic ingredient in both SUBOXONE and SUBUTEX is a partial opioid agonist, which means that it binds to the opioid receptors without triggering them. Thus, it eliminates the craving the brain has for opiates without triggering the release of chemicals that give rise to the feeling of euphoria and high. When treating withdrawal symptoms, patients can be weaned off SUBOXONE and SUBUTEX in a matter of weeks. When treating addiction, patients need them for 6 to 12 months. If you have been off opioids for more than 1 month and you decide to go back to using them for whatever reason, please do not go back to the same dose that you were using when you stopped. It can kill you. The tolerance that you developed over time is now gone. That 80 milligram of OxyContin that you used to smoke on a regular basis can now kill you. Unfortunately, many of my patients learn this the hard way. By the way, now there is a monthly injectable treatment for alcoholism and opioid addiction. It is called WITHDRAWAL, and gets the craving under control for both alcohol and opioids. Relapse prevention. Why do some people relapse? If you have a monkey on your back that tells you that you must get high, it's not a choice. No matter how strong your willpower, eventually you may fail. All it takes is one dose to send you down the spiraling path of addiction again. However, when you wake up and there is no craving, whether you decide to get high or not is a choice. A bad choice, but still a choice. SUBOXONE gives patients a second chance. It gets rid of the craving. Why then would you go back? The reason why many addicts relapse is because they forget how bad it was when they were truly hooked. They remember how good it felt getting high, but forget the misery of being addicted. For most things, it is better to forget and move on. For addiction, the price you pay for forgetting can be too high. Often an addict who relapses pays for his mistake with his life. Those who attend Narcotics Anonymous or Alcoholics Anonymous meetings do better because the meetings remind them of how bad addiction truly was. You can find local meetings by going to aa.org or na.org. I wish you well. Kyle O. MD, author of Why Can't Johnny Just Quit? Thank you for listening. Copyright Kyle O. MD. Read for you by Tal Boldo.